Good morning, David.
Good morning.
Today we have Dr. David Shechter, a medical doctor in Los Angeles, California, who is a specialist in chronic pain and mind-body approaches to healing. So thank you for coming, and why won't you start in telling us your own personal story?
Well, my personal story is I was a young medical student at New York University, and I enjoyed playing basketball and running, and they were specifically pleasures and also releases from the stress and tension of medical school. And I began to have knee pain that got severe enough that I could not run and I could not play basketball. And it worried me a great deal. I did not know why I had this pain. So I went to the student health physician and he gave me an examination and then some medication, but I did not get better. And I went back to the student health physician and I asked him for a referral to a specialist, and he sent me to an orthopedic surgeon who was very prestigious in New York City. They would see the students as a courtesy. And he recommended some testing and imaging, and nothing really showed up to explain my condition. And I began to worry more and more about it and got into that terrible cycle of, am I ever going to get better? How am I going to get back to the sports I enjoy? How am I going to be active? I'm so young, this shouldn't happen to me. I began to read in the library what could be wrong with my legs or my knees or my feet. Something had to be fixable. In the course of this, I decided to walk into the office of a doctor who had lectured to us during the anatomy class. He was a physical medicine rehabilitation doctor named John Sarno.
Oh.
He was not yet known as an author or a physician who treated chronic pain with a different type of approach. But I walked into his office expecting maybe some special physical therapy or some other approach that would cure my problem. And I walked in, I briefly introduced myself and explained the problem. And he looked at me and he said, I don't know how you'll take this, son, but 95% of this chronic pain is psychosomatic. And it was a shock. It was like getting hit with a blast wave of cold air, because it was not what I was expecting to hear from him. And he said, I can see you're a little bit skeptical. Why don't you come to my lecture that I do for patients on this subject next week? And if it makes sense to you, then I'm happy to see you as a patient at no cost the following week, and we'll figure something out. So I figured, what do I have to lose to go to his lecture? And I do remember that I was kind of, I had stress in high school, and I had some stomach symptoms, and I had stress in college, and I had some little bit of back pain. And, maybe I thought about this a little bit and said, well, maybe it's worth doing this thing. So I go to his lecture, and there's maybe 20 people, 30 people in the room, most of them very well-dressed New Yorkers in their 30s, 40s, and 50s. I was 21 at the time. And he presents his scheme of how emotions, stress, the mind, the personality, the unconscious can cause you to be in a loop, get stuck in a loop of pain.
Right.
And that's how you can get out of that loop, is the same way, understanding the emotions, the feelings, the knowledge. And by the end of that evening, I thanked him for the lecture, and I said, I'll be back next week, and I'd like to, love for you to be examine me in the office as well. I went home to my little tiny room that I had rented in an apartment that year, because I had no money for medical school. I just was trying to scrape by. And I sat down on my bed, and I felt like a weight was lifting off of my shoulders. It was like the stress and the worry, and somebody had hope for me. There was an explanation that made sense to me.
How long does this pain lasted in the knee?
It was in the months, many months.
Many months.
Less than a year, but many months.
And may I ask, what was the emotional baggage that came to it?
Well, it was interesting. At 21, it wasn't, fortunately for me, it wasn't like a deep-rooted trauma, which is sometimes the case. It was more of tension, anxiety, just not enjoying the first year of medical school, which is a lot of memorization, And then just getting into a cycle of worry where you begin to focus on your needs instead of your feelings, where you begin to focus on your pain instead of your social life, instead of your opportunities that lie ahead. And so it's different for different people. Obviously, there's people we have to help them deal with more complex traumas from childhood or from adulthood. It can be terrible, terrible conflicts, anger, grief, but sometimes it's just personality. Sometimes it's just people who are too hard on themselves, perfectionists, people pleasers, and worriers, and you get into a cycle of pain. But he showed me the way out, and he examined me and confirmed the diagnosis, asking me some questions and examining me. I went to a few more of his lectures, and then I started to walk a little faster, and I started to jog a little bit. And over the course of the next few weeks, I was jogging, then I was shooting basketballs, and then I was playing basketball. So it was really a rapid recovery once I understood that it could be real pain, but it didn't have to be due to damage. This was the key understanding. Real pain, but not due to physical damage, more due to a nervous system override or a nervous system blockage that needed to be overcome. And so the following summer, about a year later, I was able to get a research grant from the school, and I was able to spend the entire summer with Dr. Sarno in his office. And so I would see every patient he saw, and I would attend the lectures that he gave, but I was also I was using the telephone, and I was calling up a list of 177 former patients of his and asking them a series of questions I had designed with his help.
Like what?
How long did you have pain? What was your diagnosis by Dr. Sarno? Did you get better? How much relief was there with the approach that he took? What was different about it? And I began to hear the same kinds of stories over and over again, like I had, which was, I was examined by the doctor. I went to a couple of lectures that he gave. I stopped worrying about the pain. I began to feel better, and I had tremendous relief of pain. And so there was a very high success rate in his patients, which he then published in his books. He did not publish this article in a medical journal, but rather in the books that he was starting to write. I helped him edit his first book, Mind Over Back Pain. And he subsequently wrote a total of 4 books in the 80s and 90s.
So you were lucky. You were lucky that that you found him, and you were lucky that you were open enough and not being intimidated by what
being open is very key, very crucial. And I use that as one of the criteria or one of the stages of healing for my patients now. Because as I became a doctor and moved to the West Coast, I stayed in touch with Dr. Sarno, and eventually his books made him quite well known, and he began to get people telephoning his office and writing him from all over the country and in fact the world, seeking advice or to know if there were other physicians that did this work. And at the point that I was doing this work in my office, you could fit all of the physicians who did this work in a closet, and you'd have room left over for the clothing. So it was very small numbers. So he would start referring me people in Los Angeles, and I thought I would get 1 or 2 phone calls, a month or a year. The phones kept ringing. San Francisco, Los Angeles, San Diego, these are cities that are in California, and even Phoenix and other places nearby. People had no doctors to go to that knew this work. So they could read his book, but he did not like to see out-of-town patients because he wanted to have the ability to do follow-up in a more traditional manner. This was before the days of telehealth and telemedicine. He was trying to see people, of course, in the office and from New York, New Jersey, Connecticut. So he would refer a lot of these people to me, and some of them flew in airplanes to see me. Other people drove long distances, and I began to develop the same type of program that he had, which was an examination in the office and then lectures. And then in the the mid
Can I ask
90s.
you something about the examination, because he's making a distinction between structural problems and mind-body issues, but the fine line between these is very vague, because I think even he mentions in his book, Healing Back Pain, he has a chapter about autoimmune diseases, which he considers to be a TMS issue too, that it is also a mind, body, and I am interested in your opinion. What is your take on this? Are autoimmune issues, this is one question, and the other one is if someone has already a deformity created by, it might have started as a mind-body issue, but along the way, because of chronic inflammation, it might turn to a structural issue, adhesions, fusion of bones, etc.
All right, so we have the core diagnosis that he used to call tension myositis syndrome, or later tension myoneural syndrome. We use the acronym TMS. The core diagnosis is of somebody who has real physical pain, but who does not have a structural or biochemical cause for their problem. There are also people who have a structural problem, who have a broken bone, who have a massive herniated disc pressing on a nerve, who have a spinal cord tumor, etc. There are people with structural problems. I have ascertained that there is an intermediate group. I'm going to come back to your issue though as well. There's an intermediate group where you may have a mixed picture. So a mixed picture would be someone who has a structural or biochemical cause for their problem, but there's also an emotional contributing element. So there's a mixed picture. So then you work on the emotional, and sometimes you get quite a bit of relief of their overall symptoms, including maybe even more than you expected when it comes to the biochemical or structural aspect. But that group is a little more challenging to work with because you're not giving them as clear an instruction or as clear a direction with the treatment. Whereas with the mind-body patients, the TMS patients, you're saying, ignore the physical, ignore the structural, let's just work on the emotions. Now, you asked specifically about other disorders. Early on, Dr. Sarno identified that in addition to the classic, let's say, back pain or neck pain or headaches, that there were TMS equivalents, he called them, TMS equivalents. So equivalents might be stomach conditions, irritable bowel. They might be grinding the teeth. There are other conditions that he put in this category. When it comes to his final book, which was Mind-Body Divided Mind, he began to stretch out and say, well, there may also be an element of mind-body when it comes to the triggering of autoimmune disorders and other conditions. I think this is far more controversial. In general, I don't believe that TMS causes significant inflammation or deformity, because I've had patients with 30 years, 40 years of pain who, when I treat them successfully for TMS, are able to get back to moving and walking and doing things like you would expect they'd be able to do for that age without any restrictions. Does that mean that emotions play no role? Absolutely, that's not the case. For example, inflammatory bowel disease, which is an autoimmune condition, IBD, not irritable bowel syndrome, IBS, but inflammatory bowel disease, definitely responds to dietary changes in many people, and in some people responds to emotional work. And it goes into, if you will, remission. That is an inflammatory condition. It goes into remission, it improves, it may come back. But I feel like as a physician, I have to be very responsible and cautious. And I don't want to say to people, I can cure everything that you have by working on emotions. But that does not mean that I don't think that there's a value to doing emotional work for many health conditions. I just don't want to, I don't want to overpromise or overstate. It's also important because some of Dr. Sarno's work and some of his hypotheses were rejected by the mainstream medical community. And as we move forward now in the 21st century, in the year 2021 and beyond, we are seeking more acceptance by the mainstream community, and we're actually getting that gradually, and even last few years more rapidly. But to do so, we have to be careful in how we communicate what we can help and what we are not specifically treating. So I'm not sure that that gives you what you want to hear, but I am very cautious in how I communicate and how I promise and how I state that we can treat or fix things.
So thank you for the transparency. But yes, your answer was a little bit vague for me. But so let's stick to facts. Do you have case studies or your own experience with patients that they were a mixed, they had a mixed issue of something on the borderline, and you found that they were healed by this mind-body approach?
Yes, well, listen, the condition rheumatoid arthritis is a combination of examination and certain blood tests called the rheumatoid factor, which is an inflammatory marker that comes up with this condition. And the condition is believed to have a genetic element and an autoimmune element. The body kind of fights itself and irritates the joints. So in mild cases, not in severe cases with extreme deformity, but in mild cases, people who have been told they have rheumatoid arthritis, but who are not really looking to get into the kind of strong medications that are available now. Because there are now very powerful medications that can put rheumatoid arthritis into some degree of control or remission. For some patients, I have had cases.
Take a toll in the long run.
Yeah, I have had cases.
Do you mean the biological treatment?
The biologicals, yes. Very injectables or intravenous infusion medication, not just a pill, but very powerful medication.
But then people get tuberculosis. I mean, it is not an optimal solution.
No, it's not a perfect solution. So I have had patients who've worked very hard in the TMS mind-body approach, which we can discuss the details of that in a few moments.
Yeah.
And who have kept themselves away from the biologics, have kept themselves away from the stronger medication for years potentially. And I don't say that we've cured rheumatoid arthritis or they've lost rheumatoid arthritis, but it hasn't progressed, certainly. It hasn't progressed into something that has disabled or deformed them. The pain is controllable and they live with it, like you live with a lot of things. So the mind and the emotions, the brain tremendously affect a lot of processes in the body. And in some cases, those processes can be reversed by using the mind and the brain and the emotions. And in other cases, it can be controlled. In other cases, it can be affected, but not completely modified. So I think it's an area we continue to work on. But I don't know, I'm cautious in this area. I had a woman recently with a very arthritic hip. Now she had TMS in other parts of her body. In her neck, she had TMS, and in her gut, she gets TMS, this mind-body pain condition. But I said to her, your x-rays of your hip and your examination of your hip makes me believe that you really have arthritis in your hip. And that's the reason you have that pain. You're 75. I would get a hip replacement and let's use TMS for everything else. And she was so excited by this work, she didn't want to do a hip replacement. She said, I want to use this for everything. So she made improvement, as I expected, in the areas that were not osteoarthritis. She made improvement. And eventually she emailed me recently, you know what, I think I want that surgeon's name again because I'm just having a lot of pain in my hip and I can't move it. And I want to get back to swimming and things that I enjoy. So I feel we can integrate this with conventional or Western medicine. And I would love that I could fix everybody just by thinking and journaling and classes and therapy and all of that. But I've been in medicine now for decades, and I have not found that to be the case. And I'm okay.
As much as I recall, Dr. Sarno himself is saying that even tough maladies like ankylosing spondylitis or rheumatoid arthritis, he mentions it too. He says that it is all, he says it in a very clear way.
Well, I don't want to get into a situation where we're debating his books like we're debating the Talmud. I mean, I've read his books probably more times than you have.
Yeah.
And I've spoken with him personally, and I've had conversations with him personally. And obviously, I'm now involved with the next. He's been deceased for about 5 or 6 years. I'm now involved with the next generation of physicians. I have many colleagues now who do this work. Well, not a huge number, but I have colleagues who do this work in the United States and in other countries, including Israel. And having these conversations, I feel like we have a good understanding. Dr. Sarno did not treat, I mean, I know his practice well. I saw patients with him. He did not treat in his practice rheumatoid arthritis or ankylosing spondylitis as a primary diagnosis. He primarily treated tension myoneural syndrome, and he had various ways to have patients. In the last 20 years of his career, he had patients who were perhaps a borderline diagnosis or who had other complications. He said, see this neurologist that I work with first, and if he says you have nothing structural, you can come see me. And I would ask him about that. Why do you pre-screen your patients? I don't pre-screen patients. This was the point I was practicing. And he said, listen, he said, if you're the best hernia surgeon in the world, you wouldn't be having people come in for elbow surgery. He said, so I'm the best mind-body doctor. He's referring to himself. I want to see people with mind-body disorders, so I have them screened by this neurologist. I don't have a problem with that, he says. I said, okay, fine. That's what you do. So I think it's less important that we debate what he wrote or what he said than I'm sharing with you my experiences. I've treated 4,000 patients with chronic pain. And I'm also sharing with you the latest thinking in this area, because when you have a pioneer in a particular field, he builds a certain basis, and then you step on his shoulders and you build on top of that, right? So that's the way science and medicine progresses. So we have Dr. Sarno's amazing work to thank. And then obviously he's no longer with us, and he's trained or contributed to the training of other physicians and psychologists who are still with us, who are still training other doctors. Yeah.
What is your take on Raynaud's phenomenon? I mention it because also he's writing about the oxygen deprivation.
Yeah.
So it is not a poor circulation, it is a constriction of the blood vessels in the extremities. Do you think, according to your experience and your understanding, is it related to TMS?
It can be related. I think there's also genetic elements in Raynaud's that it does seem to be passed from mother to daughter or father to son, or this kind of thing. So there could be a genetic element to it. It's a sensitivity to kind of overreacting to temperature changes. Sometimes the mind-body approach is helpful, and we work on that. And then the U.S. Army actually came up with an approach that's very interesting for Raynaud's, which is you go out on a cold morning and you put your hands and feet in very warm water, in a bucket or a pail of warm water, and it actually retrains the autonomic nervous system not to respond to cold with constriction, but instead to respond to cold with vasodilation, which is what happens when you're in warm water. So that's, if you're not familiar with that, there's been some interesting articles written on that approach. I've tried that with some patients. I mean, it does mean going outside in t-shirt and what?
Did it work?
It works. Yeah, it works. You have to practice it repeatedly for a while, but
so it is kind of training the brain from bottom up.
Yeah, it's kind of training the autonomic nervous system, which we think of as not something we can train easily, but it's training the nervous system from the bottom up. Yes, and much of the work that I would talk to you about in terms of TMS is training the nervous system from the top down.
Right.
because most of conventional medicine and alternative medicine treats chronic pain primarily from the bottom up, meaning that it treats the local area of pain without thinking about where the pain is ultimately coming from, which is the brain, the mind, the nervous system, which is Sarno's insight. So we actually usually treat from the top down, but in terms of Raynaud's, sometimes you can train the nervous system from the bottom up to improve.
That's yeah. Both directions are important, but even when you do it from bottom up, the intention that you are training the brain is.
The intention is important, and then also the response. So if you have that hope, if you stay positive, if you continue to believe, yes, I can get better from this. This is not a permanent condition. It makes a big difference. And there you see a combination of how this is communicated to patients, also the role of the healer, the role of the doctor in being not just a provider of prescriptions or advice or medications, but also providing an attitude, providing a belief, a hope, and and how that plays a role in many of these conditions that have a functional element.
So is there a case study? I still stress on your success stories. So besides the musculoskeletal issues, which are coming from an emotional cause, have you been surprised in your clinic, like someone came to you and you were doubtful whether this approach would work and you were surprised?
Over the years, I believe that I have expanded expanded the kinds of conditions I treat, in part because patients were saying, let's try this. I'm willing to try this for a while. And I give them credit for the courage to do so. And that has helped us. So initially, Sarno's books were really about back pain. He wrote Mind Over Back Pain, Healing Back Pain, his first two books, right? And so when I went out into practice, I started treating mostly back pain because that's what people had heard about in association with this disorder. And of course, some neck pain. And then we had this run. We had this almost epidemic when the computers became more common and keyboards, and all these computer people were saying, my arms hurt, I'm getting arm pain. And then sometimes they would even get traumatic changes there. They would get color changes in their hands and things. And it was called repetitive stress syndrome, or it was called upper extremity overuse syndrome. And it was in the late 90s and early 2000s. I saw a lot of this. So I said, well, let me try. This doesn't seem physiological. Let me try using the same approach with these people with arm pain. And I began to get great success with this. And so that expanded my work. He eventually wrote about this in his book, The Mind-Body Prescription. But I began to get great success with arm pain. And so, I've worked in this field. And then now the last few years, I've had a number of successes in migraine headaches. So I've expanded a little bit the work in migraine headaches because I've had cases. Recently I had a physician who had migraine headaches for years, treated every medication, seen every doctor, and then she was open to trying a little different approach. So we delved into the emotional, and literally within 2 months, she was off of the medications and her headaches were gone. It was amazing. Beautiful. And then we had another man who was 75 years old who had headaches for 60 years and migraine headaches. And the last 9 years, he was debilitated. He couldn't travel. He couldn't see his grandchildren, all this kind of thing. And he came in, and within a couple of months, he had made a dramatic progress. So I definitely think that over the years, we've expanded the conditions. I mean, Sarno always said that headaches could be treated like this. And he mentioned migraines, but until I guess as a physician, until you've had some of the personal success stories, you're a little bit, more hesitant to jump into areas that you don't have as much clinical experience with. But there's many conditions that this is helpful for. It's primarily helpful in the chronic pain that does not have a structural problem or does not have a significant structural problem. So in back pain, we often see a bulging disc 3 millimeters, whatever. That doesn't mean anything. That's like gray hair of the spine. That doesn't have any significance. But there are other people that have more significant structural problems. So I try to be very objective about this. I don't believe that TMS is a religion or a philosophy. I think it's a treatment program. I think it's an approach to healing. In the process of doing that approach to healing, one can benefit greatly in terms of personal growth, in terms of understanding of oneself, one's environment, et cetera. I had a gentleman yesterday who has struggled a little bit in his career, has been sort of stuck in his life for many years. And we had a very long conversation we did a video call because for whatever reason, he didn't come in the office. He didn't live that far away, but I said to him, this has to be transformative, not just of your thinking about your pain, but really about your whole life, because you're in a cycle, a stuck cycle in your life, and you're in a stuck cycle in your pain. So you've got to break out of both of them. And I think he liked that message. He appreciated that message. So there are times where TMS work goes well beyond just eliminating the pain. It can really help you to break out of things in your life that are holding you back.
To grow.
But it's not a philosophy. So it's not a religion. So it's not, believe in this regardless of what I say, and you will be healed. I do. And Sarno really did emphasize this to me. He always said, it's a medical diagnosis. He said, doctors should make the diagnosis. He said, I understand that people read my books and they get better sometimes. And that's great that I can make them aware of this, but primarily it should be a doctor's diagnosis. And then treatment can be by that doctor or by a psychologist, psychotherapist, or by the patient just reading books and watching videos and things like that. That's fine, as long as they're clear with their diagnosis. So that was one thing he emphasized. I continue to hold true to that. Now, there are some psychotherapists who feel like they're confident enough in, if you will, diagnosing TMS, that even though they're not medical doctors, that they begin the treatment. They begin treating people with chronic pain through psychological means. And some of them have great success with this. And then some of those patients I end up having to see because the patient really needs to hear from a physician, yes, this is TMS. Yes, you don't have a structural problem. You don't have a spinal issue.
What about soft tissues, like issues like plantar fasciitis or Dupuytren, things that have to do with constriction in
okay, so those are two good examples. So let's differentiate those two examples. So plantar fasciitis is typically pain in the bottom of the foot, often near the heel. And it's a soft tissue problem. There's a fascia, there's a connective tissue that goes from the heel bone to the feet, to the metatarsals, the front of the foot. And it can hurt. I'm going to jump over to Dupuytren's. Dupuytren's is a contracture. Dupuytren's is when the hand actually begins to develop a contracture.
Yeah.
Sometimes the finger won't extend fully, and there's a tightness, and you can feel a thickness to the pad. So I would differentiate those two conditions, because plantar fasciitis is more of a functional condition of the foot, and Dupuytren of the soft tissue of the foot, and Dupuytren's is more of a structural contracture of the tissue of the hand, usually the hand. Plantar fasciitis can be treated in a couple of ways. If you have a week of plantar fasciitis and you've been maybe playing a lot of tennis, or you've been started a running program, you might want to take a golf ball or a tennis ball and roll your foot on it, or a dowel, a piece of wood that's round, and put it on the ground and roll it under your foot. And that may be all you need, just to stretch your foot, increase the blood flow, loosen the soft tissue, and you get better. And if you do, that's fine, because as a sports medicine doctor, a lot of acute pain, acute means less than 6 weeks or less than 3 months. A lot of acute pain is going to get better regardless of what you do to it. And, massage or stretching or rolling it is very effective.
Or just a spontaneous remission. Yeah.
Well, spontaneous, or perhaps it's the normal, it's what the body does, which is body gets injured, the body heals. I mean, we've had thousands of years of this before we had doctors or healers or anything else. The human beings walked around and got injured and healed, or perhaps sometimes they got infected and died, but that's a separate issue. Now, with regard to Dupuytren's, you can try local treatments and stretching and that type of thing, it doesn't have a lot of effect, because by the time it becomes obvious, it's been going on for years at a lower level, and it kind of contracts the hand. So you can do, physical therapists can do some work on that, but it doesn't tend to be that effective. Now, I'm now going to go on to someone who's had plantar fasciitis for a few months, perhaps, or did not respond to the initial treatment of the tennis ball or the wood dowel, the rolling pin, as we call it, a treatment. So if I interview them and I talk to them, and they're a TMS prone person, they have the type T personality that we might discuss, and maybe they have stressors in their life, I can often find, I say, well, listen, you've done those physical things, you haven't gotten better. I examine their foot, I look for the tender points on their back that we could discuss, that these markers that are associated with TMS. And I say to them, let's work on it more on a mind-body basis. And I do get very good results in people who have tried and failed the conventional approaches to plantar fasciitis. And the mind, the brain works, and the tissue relaxes, and they're back to normal. They get back to normal over a period of time. It's not like it happens like that, but they get better. With Dupuytren's, I have not tried that, nor do I believe that that is the way to go, because it's a soft tissue contracture that will not open up just because you're thinking differently. In my experience, maybe I'm wrong, but this is my knowledge and my experience.
Let me suggest something which aligns with the Dr. Sarno philosophy. When someone have loads of anxiety and anxious thoughts and as he calls it, repressed emotions, especially rage, and he says that it is causing a mild oxygen deprivation, i.e. less circulation, less oxygen coming to the extremities. Isn't it possible that this, and as you said before, the type T personality has a tendency to brace, to tighten, and we know that fascia is by default receiving less blood supply, and so couldn't it be that long-term stressors that cause a compromised circulation to the hand, to the palm, can start these adhesions and scarring in the fascia?
Well, it's certainly possible, and you lay out a series of hypotheses in that area, but there has been no confirmation of that methodology or that hypothesis, and there has been no evidence from any doctors that I've spoken to. Now, I worked on a book recently with Dave Clark and with Howard Schubiner. These are other leading thinkers in this area.
They have been interviewed too here.
Okay, and we wrote a book together. It hasn't come out yet. It's being edited, and it's actually going to list like 500 disorders. And are they TMS or are they not TMS? You know, are they? We use the term psychophysiologic disorders, PPD. Yes. Are they PPD or are they not? And we took turns. You know, I would answer 20 and he would do 20, and we all answered the questions. And then there's editing going on. So when that book comes out, you'll have more information. The other thing I'll say to you is, remember, Dr. Sarno wrote 4 books at a time where there was less scientific evidence about the brain and the connection of the brain to the body, et cetera. He made two hypotheses that are worth commenting on. One is the idea of oxygen deprivation, that the pain in the body was primarily due to the autonomic nervous system creating an oxygen deficit. That hypothesis, while he thought there was a little bit of evidence in a couple of research studies, has not been confirmed. He felt that the autonomic nervous system, the fight and flight response, was playing a role in TMS and chronic pain. That, I would say, to a greater degree has been supported. But the blood flow hypothesis is not something that the modern doctors really emphasize or use. I mean, if a patient comes in with that idea and it's useful to them, I let them kind of work with that. But I focus a lot more on the brain. I focus a lot more on the nervous system. I focus a lot more on obviously on the typical stuff, your feelings, your anger, your frustrations, your grief. But this hypothesis of blood flow and constriction has not really been confirmed. So it's something that, again, you can begin to create. You don't want to create a house of sand, piling sand on top of sand. Right. It's nice on the beach, but then if you hit it, it washes away, right? You want to build a firm structure. And to do so, you use a combination of empirical observation, which Dr. Sarno was brilliant at, which is observing reality and creating a theory. And you also use science to create that stiffness, that power of knowledge. And so we have a lot of science about the brain. We know that acute pain is experienced in one part of the brain, the somatosensory cortex. We know that chronic pain, if you look at somebody with 3 to 6 months or more of pain, it's a different part of the brain that lights up. It's the amygdala and the prefrontal cortex. And that really provides, I discuss this in my book, Think Away Your Pain, that really provides the science that we've been waiting for to prove that Dr. Sarno's hypothesis that chronic pain is more related to the emotional centers than it is to the sensory experience is true. Because acute pain, if you sprain your ankle, it's not an emotional experience the first hour. You may be angry at yourself, but it's not primarily driven by your emotional life. But if that foot or that ankle or that back or that neck or that knee continue to hurt for months, it can be a very emotional experience, and it can be, in fact, purely an emotional experience mediated through the brain and the nervous system. So
how do they see it with the functional MRIs?
Yeah, functional MRI scanning. Yes, there's been a tremendous amount of functional MRI studies, some of it out of Northwestern and University in Chicago by Apkarian and Hashmi and others. And these functional MRI shows that the blood flow in the brain, where does it go if you're having pain? Where does it go if your pain persists? There's differences, and this is very powerful information. The other thing from Howard Fields in San Francisco was, it was always thought that pain was a one-way street. So if you have your arm hurts, it comes up the arm and to the brain, and you go, oh, my arm hurts. But it turns out your brain is constantly sending signals the other direction too. So when we sat down 20 minutes ago or so to start talking, you're sitting, I think, on a bed or a chair, I'm not sure. I'm sitting on a chair. Our bodies briefly became aware of what we're sitting on. But then the brain doesn't need that information anymore. So it's continuing to get the signals that from your body that you're sitting in a chair, but it just shuts them down. It sends a blocking signal, right? Ignore. But if you sit there long enough, the brain will go, oh, the signals are getting a little bit strong. Maybe I should let those through. And then you kind of adjust your position, right? You move around. Oh, now I'm comfortable again. I can talk to a not someone. So that's how the brain is constantly dealing with information. It gets a tremendous amount of information, and it's letting some in, it's blocking other things. Now, if you talk about information coming into a brain, into a person that is stressed, that is upset, that is worried, that is angry, instead of the brain saying, oh, this is going to go away in a day, it's no big deal, I played soccer yesterday, I'll be fine tomorrow. It's worry, it's amplification, it's fear, and then it becomes a vicious cycle. Then you have a nerve pathway develop. And I think this is a better explanation for the type of pain that Dr. Sarno identified, and for the healing of that pain, than the blood flow mechanism. If I've had a few scientists, and not scientists, but more like technicians and researchers actually discuss with me, there's more technology about blood flow. They wanted to come and measure blood flow in some of my patients before and after treatment. We may eventually do that. There's been some attempts to do that, but I don't know that that's going to really be as powerful an explanation. And I don't think it would necessarily explain the development of Dupuytren's or other things as well. The blood flow in the body.
These two theories, as I see it, and correct me if I'm wrong, they are so related to each other, because if someone is feeling anxious, what is he doing? He's tightening, he's bracing, he's in a defensive mode. Now, if he does it all his life, if he's hooked in the sympathetic branch of the autonomous nervous system, what happens? Everything constricts, the vessels, the muscles, the fascia, the internal organs, the lymph nodes or the lymph vessels. It seems like this, even if you just make now an experiment and tighten your hand or tighten your arm or tighten your neck, you would feel that I see the correlation between the fMRIs.
Well, a lot of what you're describing with tightening and bracing are very important concepts. But, you can tighten and brace for a week, you can tighten and brace for a day, you can tighten and brace for a minute, you can tighten and brace for years. I don't feel like it by itself it maybe takes it deep enough scientifically to explain what's happening, but it's a useful way of discussing it with people. I mean, tightening and bracing, many of the therapists talk to people about this. I will bring it up at times. I think that your concept of tightening and bracing is a good concept. I just don't think that the description of blood vessel constriction is a good enough explanation. It doesn't have enough scientific support at this point to say that that's how the pain is happening. We're having a nice little debate. It's fine. I don't, people like to discuss, and all of that's good.
What can you say about the bracing pattern, which is very tricky, because I think most of the time it is unconscious.
Yeah, well, here's what I tell people. This is people who have now come into my program, been diagnosed by me. Here's what I tell them. People with TMS are tightening, they're clenching. Exactly. Now, what I tell them is there's a continuum between thought, the nervous system, and the body tightening. So what I say to them is you have to catch it earlier and earlier. If you wait till the point at which the body is already tightened and in pain, it's going to be harder to reverse it. You can do that, but it's harder to reverse it. So you start making your mind more aware of the tightness. And if you catch it earlier and earlier and earlier in the cycle, eventually you get to the point where you're catching it. That is the clenching or the tightening of the muscles. You're catching it just after it was an emotion, just after it was in the brain, just after it was a thought, a worry. And eventually you get to the point where you're starting to really notice it at the emotional level first. And that is very powerful and usually leads to the ending of this problem, because if you're dealing with it at the emotional or abstract level, rather than at the physical clenching level, you're no longer having the pain. Then it becomes, well, how do I feel right now? And that's the goal. And that's what we teach people. How are you feeling now? Check in with your feelings.
What you're saying, this is a very interesting point, what you're saying now, because it reminds me the Chinese saying that, 1 gram of prevention is much better than 100 tons of treatment. So actually what you're saying is to catch the thinking or the feeling, to catch the problem upstream before the whole river is contaminated. Like what are you striving for? To teach your patients to catch their thoughts or their emotions on the fly?
Yes. By the way, I just want to make a slight correction. Benjamin Franklin in the United States said in 1736, an ounce of prevention is worth a pound of cure.
Yeah.
I'm not sure that the Chinese ever were involved with that. Maybe they were and he read Chinese, but I know that Benjamin Franklin has credit for that in the United States in the English language. But yeah, that's why I am telling people to really check in with themselves. How are you feeling? And this is something that is very useful for people to do, because many TMS people are initially shut off from their feelings. So there are feelings going on, but they're shut off, they're blocked, and they're expressing their feelings with physical symptoms. So they come to their doctor or they come to their whatever, and they say, my arm hurts, my back hurts, my neck hurts. And of course, the doctor says, oh, you must have injured it, right? Oh, maybe I slept wrong. Well, of course, people know how to sleep. I don't believe in that sleeping wrong theory, because to me, that's nonsense. You know, you sleep every night, you're pretty good at it.
And the body can adapt always.
Body can adapt to sleeping on the floor, sleeping on a comfortable bed, sleeping on a harder bed. You know, maybe you feel a little differently, but it doesn't create an intense pain. So what then would be the reason why that day somebody's neck is hurting them? And it could be the feeling. So the doctor should say, well, I don't really find much on examination. You have some muscle tightness. It's not serious. And then should shift and say, what's going on in your life right now? And the patient might go, what does that have to do with my neck? But if he's willing to listen to that question, he might say, you know, my wife and I have been fighting lately. It's very stressful. It's very, difficult. Or my teenage son is going through some difficult times, and that's been worrying me. So then when he begins to confront the feeling, that's the beginning of the end of the pain, because you don't need the pain anymore, right? You're dealing with the feeling more directly. And that would go along with sort of the theory that Sarno presents, that the pain is a distraction from the emotion, so that you don't have to confront the feeling, which can be sometimes more powerful. It's at some level, it's easier to have a back pain than to realize that your marriage is not going well, or your child is struggling. It might be more threatening to the person than to have a back pain.
So
What
is the hierarchy according to you? First the thinking, then the feeling, and then the physical manifestation, or is it the feeling, thinking, and the...
I think feeling seems like it's primary. There are times where we explain something in a very rational level, but I think research suggests that it's really a feeling first. You know, sometimes you make a decision and you say, well, I decided to do this because, but really it's like you made the decision because you either want something or you want to avoid something. You know, it's either going forward or staying away. So I think the feeling is first. And then the feeling can provoke a thought, or you can look at it with thoughts. The feeling is first. And then the feeling in some people directly connects to the body and the clench or the tightening or the change in the nervous system response, or in your hypothesis in Sarno's early work, the blood flow, whatever you want to call it. It's changing something temporarily in the body that leads to the pain or the discomfort. And again, a big focus of Dr. Sarno's books and his work was that TMS is reversible and it's curable. And if it created a large amount of inflammation, which I don't believe it does, then it wouldn't go away sometimes in an hour, sometimes in a minute. And I don't mean permanently necessarily, but how could you have inflammation for 10 years and then be sitting with me in the office, which I hear people say, just talking to you about this, I feel so much better. You know, that's
when you talk about inflammation, do you mean if they have biomarkers in the blood tests? Like the...
I guess I'm thinking more of like inflammation at the physiological level or at the tissue level. So we were discussing this recently in one of these groups that I'm involved with. Someone was saying, well, you know, there's a lot of evidence for inflammation in chronic pain, and maybe that's what's going on here. And then somebody else said, I think very accurately, that inflammation takes a while to develop and it takes a while to go away. And the fact that we sometimes have these dramatic turnarounds in symptoms would not really support an inflammation basis for a lot of TMS pain. On the other hand, the nervous system can flip like that. I mean, you can go from awake to asleep and you feel completely differently in a second, right? You're awake and then you doze off, you're asleep, you don't feel anything. Wake up again, you feel something different. So the nervous system can go on and can shut on and off, and you can go through dramatic changes in feelings. You know, you're upset, and then a friend shows up at your door and you feel completely different. You listen to some music, you feel good, and you read something, you feel bad. So feelings can shift very quickly. The nervous system can shift very quickly, but inflammation takes quite a while to change. I mean, if you hit your knee against a door and it gets swollen and you put ice on it, it doesn't go away in 5 seconds. It may take hours, it may take a few days to get better. You know, eventually inflammation goes down. But so I just am making that distinction for you and for people that primarily this is not an inflammatory condition that we are treating.
But do TMS patients with the classical issues like back pain, neck pain, fibromyalgia, migraines, do they have swelling?
I don't think so. I don't believe, generally not. Now, I'll give you one example where this might be an exception. So in these people with the arm pain, you know, the RSI type pain, repetitive strain, it seems like sometimes the autonomic nervous system got so screwed up that I would see swelling, discoloration, other changes in the skin or in the arm, and these would get better. These would get better over time. It wouldn't go away in 5 minutes, but these would get better with people beginning to lower the fear level and starting to use their arms again and trying to understand why their work or their life created such a severe dysfunction. So that's almost like grabbing somebody back from the brink and then having them get back to normal. But it doesn't happen overnight, of course. But in general, I don't think that there's swelling. What
about eczema and atopic dermatitis, rashes? I think
rashes certainly are changes in the skin. There's redness, and at the microscopic level, there is some inflammation. So, in terms of eczema, I would say that would be an example of an inflammatory condition. That's a good example. That is probably triggered in many people by stress. Not everybody. Sometimes it's triggered by soaps or shampoos or dry wind, dry air, or something like that. But it can be triggered by stress.
Yes. So let's talk about safety, because we talked before about the person who is trapped in the fight or flight freeze mode. What is your take on how to cultivate? How can people learn, such people that live in emergency state, how can they teach themselves to cultivate a sense of safety?
Well, they can start with understanding what's wrong with them. When you believe that you have a severe problem, when you believe you're not going to get better, when you believe that you have damage to your body, then it's hard to break out of that cycle. When you hear about a new explanation, a new diagnosis, a new approach, we call it TMS or psychophysiologic disorders or mind-body medicine, it can shift. They begin to have belief. And when they read that the personality that we look for, someone who's hard on themselves, someone who's sensitive to how others perceive them, a goodist, someone who's very upset they can't change the world for the better.
The perfectionist
sometimes. So when they begin, oh, that's me, that's really me. And then when they hear that certain childhood factors can be relevant, and they go, yeah, I had some of those issues as a child. Maybe there was divorce, or I wasn't listened to, or there was a lot of pressure at home, or I put a lot of pressure on myself. My parents put pressure on me. You know, they begin to go, well, yeah, this fits me. I see this as me. And I worry so much about just not getting better. And so when you begin to just talk to them and say, I've had other patients like you. When we diagnose them as TMS, they start thinking differently. They start feeling differently. They start doing, and then, then we move into the You know, the processing of emotions. Journaling is one of the techniques we use, writing about your feelings. And we use education. You know, there's books to read, there's videos to watch, there's courses online to look at. So all of these things contribute to a sense of hope, and hope leads to eventually a feeling of security or safety. And then sometimes you have to talk to yourself, and it's almost like we say, fake it until you make it. So you have to say to yourself, I'm going to be okay. I can get better. And then by doing that, it creates a difference, a feeling in the nervous system from fear to hope, from insecurity to security. So that's the process by which
what you are saying is you gave two tools. One of them is acknowledging what is in front of you, that your body is okay, and it is the mind, the brain is creating all this pain. And the other thing that you mentioned was about the inner self-talk. How do you talk to yourself and calm yourself?
Yeah. So self-talk, affirmations, acknowledging feelings, expressing feelings. These are important parts of this. I mentioned journaling, which is writing about feelings. That can be a very useful tool because we want to get you out of your head and actually doing things. So I get people writing about their feelings for 10 or 15 minutes a day, either in a blank notebook or I've written a workbook for this purpose, the Mind Body Workbook. And we get people physically moving. So people might be very hesitant to walk or to bend or to move or to swim. So I get them doing some type of activity. This represents the physical element of action, so that you're not just in your head about this. But at the same time, you have to be in your head. You have to be thinking about how you can shift your perspectives and your conclusions and your thoughts.
Many people don't like journaling in the TMS community because they say they are writing their depression. They are writing their way to depression, because if they start to dig in the past and wallow and dwell in the traumas.
Well, let me give you the following. First of all, in the anxiety treatment world, some people say to their patients, I want you to take 10 minutes a day to worry as much as you want about anything that you want to worry. And then the rest of the day, you can't worry at all. If you start worrying, you tell yourself, don't worry. So it sort of like confines the worry to 10 minutes a night. Sometimes people can't think of 10 minutes when they actually sit down. It's hard to worry for 10 minutes straight.
Yes.
But at least it gives you a time to do it.
Yeah.
So I would say the same thing about journaling, which is that we have these feelings inside the whole day. I'm just saying for 10 or 15 minutes, put it onto paper and then stop, close the book, walk away from it.
Nice.
I'll also tell you two things that can be helpful to your listeners who are feeling like journaling is taking them down too much. So this is something that I've added over the last number of years. One day a week, I ask them to do gratitude journaling. So you're not writing about the past. You're not writing about bad things. You're making a list of 3 or 4 things that you're thankful for. And you're writing a paragraph about each one of those things. And there's a lot of research that suggests that writing about being thankful or listing things you're grateful for improves the mood, even treats depression. So that can be one day a week. Another day a week, I have them do what I call self-esteem journaling. So write down 3 things that you like about yourself, or if you can't think of 3 things that day, write down 3 things that other people like about you. And then write a paragraph about each one of those things, or an example of how you did one of those things that you like about yourself. And again, so that changes it from a 5, 6, or 7 day a week of I'm sitting down and I'm writing about misery to 2 days a week you're writing about positive stuff, and then 3 or 4 days a week you're writing about feelings that need to come out. And to say that writing about these things makes you wallow in depression tells me that you need to treat your depression, and maybe you need to meet with an individual therapist and discuss it. But I'm telling you, when you go to a therapist and you talk about depression, it's not going to be all happiness and joy. There's going to be some crying. There's going to be some weeping. There's going to be some sad feelings, but that's how you get it out. So all of the research, all of the clinical experience of 100 years since Freud is that talking about one's feelings is better than holding it inside.
Yeah,
And
sure.
I know that in Israel, they're very advanced in trauma therapy. They have trauma therapists who show up at the site of a horrible attack, of a terrorist attack, and start talking to people right away.
Yes,
Even 5 minutes after the attack, if they're not severely injured and they have to go to the hospital, they start talking to them.
that's
So
right.
tell me what you felt. What are you feeling now? Okay, it's okay. You know, they know how to talk to people. They've been trained and experienced to talk to people right away, not to wait 2 months or 2 years to talk to people, but as soon as possible. And obviously they know how to do it in a way that they're not making them worse, they're making them better. So one of the things that human beings have is speaking and writing about feelings and getting it out onto paper. So it's not easy, but it's worthwhile for most people to do this. And if it makes you too depressed, then I would say you need to have an individual therapist who understands this field as well, of which we have many to help you.
Now I want to go back to your personal experience with the knee pain.
Yeah.
If you go back to that time in your life when you were worried and the worry perpetuated the pain and vice versa, and it was a vicious cycle. If you had to give now as a regular human being, like a mere mortal, not as a doctor, what advice would you give now to someone who is listening to you and who is struggling with a chronic pain or a chronic condition? Let's take it to a chronic condition to make it more generalized.
I think my advice would be have hope. You know, hope is always worthwhile to have. If you're not happy with the current physician you see, maybe see a different one. Ask your doctor if you can include psychology and emotional understanding in your treatment. If you're working on your own with a chronic condition, look at some of these ideas. They're online, they're available online. There's websites that we can mention, et cetera, that you can get them good information. And be open to this. You have nothing to lose by looking into this, and maybe a lot to gain. So you get stuck in a chronic condition when you feel like there's no way out, and you feel like that nobody has an answer. And I find that you often get improvement if you are open to the idea that your mind and your emotions and your feelings are important and maybe contributing. So if the mind is the way out, it does not mean that it's your fault. It does not mean that you didn't know about this. You didn't know about this approach. You didn't know about this, this method or this approach. So I'm not looking at this as this is your fault. I'm looking at this as maybe this is a way that you can harness a part of your body, a part of your being, to heal or to get better or to feel better. And so I think that's the important message.
So last two questions. Is there a recommended book? I know that you wrote a book, but and not necessarily on the area of chronic pain, but about the healing process in the body. Some book that affected you, that you were impressed by, that you recommend?
Well, there are many good books, and I have them on a list that I give out to patients, and I have them on the list that's in my course as well. I was thinking of a book by Wayne Jonas, Jonas. He's not a TMS doctor. He's a physician who was involved with the National Institutes of Health in the United States, and he's been involved with different mind-body clinics. I like him. He's very sincere. His wife had cancer, and he tried to develop a healing environment for her at home, and he discusses it very well. I'm forgetting the title of his book, but you can find it if you look up his name, Jonas. First name is Wayne, Wayne. So in terms of the general philosophy of healing, it's a very good book. It does not specifically address, in my opinion, the TMS diagnosis or approach in a sophisticated way.
Why did you like this book?
What?
What was about that book that you liked?
I think I liked the fact that he took a very integrative approach to healing and a healing environment, and a very compassionate man. And he did understand the importance of integrating psychology and physical treatment and all of that. You know, some of you who dealing with a chronic condition may find it helpful in that regard. In the regard of the pain and things, you know, the books in my category are the ones that I tend to advise.
And the last question is again, it goes to the advice, but you know, we have a saying, there is a saying that quality questions lead to quality life. Like asking the right question is creating more clarity, and it gives you a good vector, a good direction to go. So what would you advise your patients or people with pain or suffering to ask themselves that would open their eyes? And
I think I would ask them to ask themselves, what in my life would I change if I could? I would ask them to say, what would I do if my pain or suffering went away tomorrow? What would I do with my life? And what stops me from doing that now, even though my pain or suffering has not gone away, to the best of my abilities? So it kind of reverses the problem, because a lot of times people will say to me, I'll do this once the pain goes away.
Yeah.
And I say to them, well, actually, the way to make the pain go away is to start doing this. Now, I understand if I can't ask you to run at high speed if you're not physically able to do that. But when it comes to bigger life goals and missions, ask yourself if you could start taking the steps in the direction of doing what you really want to do with your life now, even before your problem has gone away. And you may find that that is a step toward making that problem go away.
beautiful. Thank you so much, David. It was fascinating to talk to you.
Enjoyed speaking with you as well. Thank you.
And I learned a lot. Thank you. Thank you so much.
Be well.
Thank you.